See, patients with fatty liver, obese, and diabetes, obviously ultrasound, when it comes to HCC surveillance, ultrasound is very suboptimal and it's very user dependent on the operator. So what are the modalities? You said PET and all those things, but for surveillance, what would be the future recommendation?
Thanks Dinesh for that question. I think that's an excellent question, and we were talking about this in the morning today also at the SIG. And as I said, I think abbreviated MRI is the way to go in these patients. And I think abbreviated MRI, there are two ways. Either you start off surveillance with ultrasound, and when you find that your ultrasound surveillance is not great, you have a visualization score C, maybe it's time then to shift over to abbreviated MRI for surveillance in those patients. The other way is that if you have a good ultrasound surveillance, I think rather than a 1-year CT scan or 1-year dynamic imaging, you may have to do a 6-month imaging in these patients. Because today there was a case presentation in the morning, 3 months back, this patient had absolutely nothing on ultrasound surveillance. And he comes 3 months later with a large infiltrative tumor of the right lobe of the liver with a PIVCA of 18,000. So I think ultrasound is really suboptimal in these patients, and I think we have to take the next step to define how we are going to screen these patients.
Sir, excellent talk. Just a question. How much the explant helps us to identify recurrence? Means I am referring to this term steatohepatic HCC, which we see on explant. It was described from Gangaram Hospital only. So does this type of studying of explant helps us to determine recurrence and change our immunosuppression strategy?
So thanks for that question. I excluded those slides actually from my presentation for want of time. What we found is that there is no difference actually in terms of prognostic markers on the explant. Whatever explant prognostic markers are there in other HCCs which are non-MAFLD or non-MASH HCCs is the same. The microvascular invasion, the grade of differentiation, the grade was never actually a difference for us, because if you see in the Indian population, a majority of patients, almost 90% of the patients are moderately differentiated HCC. So we get a very small proportion of those poorly differentiated ones, which are now increasing to about 12% or so, which indirectly a surrogate marker for there is FDG18 PET avidity. So I think it's not different as compared to the general post-operative explant prognostic markers. It's the same for macerated HCC. That's what we found. And therefore, in the multivariate analysis, none of these factors came up.
And about the comment on Madam's talk, I wanted the Indian perspective about this integrated alcohol relapse prevention. How do you see the acceptance of Indian patients to get enrolled in such a program and adhere to it, particularly from the living donor setting in India? Means ma'am can also comment, but in India, what do you find practically happening?
So, this question was asked to me also when I presented this plenary paper in this year. And there is a difference in between India and the West, and I think the reason why we have low rates of recidivism is because our families are closer. I can say this, that the family support that comes from, the close family who's staying together and supporting and making sure that this person doesn't go back to alcohol has a huge role to play in India. And that's the reason why we are at 12%, whether others are at 25% relapse rates. As far as the acceptance is concerned, in living donor liver transplantation, the second aspect is the donor is your family relative. And therefore, there is something that that patient has to give back to the family or give back to the donor. The least he can do is not go back to alcohol. So I think if you involve the family in this post-operative counseling and care, that has a huge impact.
Dr. Russo, can you join us here, please? Please.
Yeah, so from a West perspective, we don't find any difference. We also do a living donor liver transplant and a deceased donor, and the rate of relapse happens also in living donor liver transplant. And majority of these living donors are still family members, spouses, or children or parents. And when relapse happen, we don't see any difference. I think. Maybe there is something about the family connection, cultural issues that is different between East and West. And in terms of our patients, so if they are not willing to participate to the relapse prevention, we don't transplant them. That's very simple.
Okay, thank you.
Dr. Selzner, to continue on that, I mean, do you see a difference in the response between the alcoholic hepatitis group as opposed to the alcoholic liver disease group in terms of how they cope with the relapse prevention program?
In our series, we haven't found much of a difference. But majority of the patient in our patient populations that has been transplanted were either ACLF or decompensated liver disease. Even those that we initially thought are severe alcoholic hepatitis, the explant shows that in fact they were cirrhotic and is more like an ACLF form. So we didn't find any difference.
The implementation of the program, what you did, whenever there is alcohol, liver disease patients who drink after recidivism, after transplant, there is parallels with the non-compliance of immunosuppression, with rejection rates, chronic rejection, etc. Did those things come down with your program, or?
No, because really the non-compliance are very, very minor group in our whole transplant recipient. Non-compliance and rejection are really, really rare. We don't have many of those patients. And we didn't find any difference in reduction of rejection with the implementation of this program, definitively not.
Just a question towards Prashant and Dr. Russo. You know, I see. I agree. MSLD is a huge problem. I remember about 15 20 years back, we published a paper on differential risk of post-transplant malignancy, which was a large series from King's College, and where the alcoholics had I think 3 times higher risk of malignancy post-transplant de novo. It was a clear difference, in fact, that was with John O'Grady. And then it was believed that as alcoholics, because they are primarily prone to a lot of malignancies, alcohol is a strong factor for that. Now I realize that the last 2-3 years, suddenly MSLD and malignancy is being linked more and more and more. So is there a bias, or have we do you want to say that between alcoholic group and MSLD, the risk of de novo is more in MSLD and not in alcohol? That's a thing which I want to understand from you both.
So I think, as I showed in the slide, there are these 3 which are supposed to be highest risk for developing de novo: alcoholic liver disease, MASLD, which was initially NAFLD, and primary sclerosing cholangitis. Those patients who undergo transplant for these particular things, of course, there are specific cancers which happen in patients who have specific etiology. I didn't put that table there, but there are specific cancers. But especially with metabolic associated steatotic liver disease, there are these 3 or 4 cancers which are more common. Colorectal, you've got ovarian, genitourinary cancers, and you also have lung cancer and thyroid cancer, which can be predominant in these particular patients. So I think it's not to put down alcohol. Alcoholic liver disease, MASLD, and primary sclerosing cholangitis, I think, are the 3 factors.
I totally agree, and the other thing that I showed in the huge meta-analysis that has been published by the group of Singapore, actually they checked for the mortality after the transplant, and they couldn't find any difference between the malignancy being one of the risk factors for mortality after transplant. But all the limits that have the meta-analysis, and I totally agree that after the transplant we need to be, and of course we need to be we need to have a proper screening after transplant, restarting doing colonoscopy after, I don't know, in our, it depends how old are the patients that go to transplant, but you have to be clear what are the pathway after the transplant.
I just had a comment to make. So, metabolic syndrome includes obesity and diabetes. And it's been known that insulin resistance, the presence of obesity, and diabetes are interrelated. Obviously, with obesity, the insulin resistance rises and diabetes becomes worse. So, in itself, the presence of insulin resistance, diabetes, and obesity are risk factors for cancer in general, right? So, you think that has to do with the higher or more aggressive cancer that you might get with NAFLD.
I mean, from my point of view, yes, there is something that is from a pathophysiological point of view that it can help in growing cancer cells by the insulin resistance as well. This is something that has been already demonstrated that for this reason we need to be very careful with these patients.
Yeah, thank you. Thank you, my co-chairs and all speakers.